Hi, this is Dr. Sherry Shabowski from Medical Education in Minutes. This is part of the classic clinical presentation grouping. Today, we're going to meet Drew Nefros. Drew Nefros is a 66-year-old male who presents to the ER in agony. He is diaphoretic. His blood pressure is 220 over 110. His heart rate is 139. Respiratory rate is 24, and he is afebrile. He relates that on a scale of 1 to 10, his pain is an 11. He relays that he was fine this morning. He has a past medical history of prostatic hypertrophy, and he does not have high blood pressure. He has been straining to urinate over the last few months and has to get up in the middle of the night to urinate. He frequently feels that he cannot completely void his bladder. But today, he has not been able to get any more than a few drops out. The nurse comes in. Both medical professionals are impressed by the patient's overt discomfort. He is in so much pain. The nurse asks, "Should I get pain medication? How about medication for his blood pressure?" The doctor palpates his abdomen and says, "I'll get the ultrasound and you go get a Foley catheter." Before treating severe hypertension, always consider the etiology. If the MD chose to manage the blood pressure before fixing the problem, the blood pressure medication might kick in when it is no longer needed, leading to iatrogenic or doctor-induced hypotension. The doctor does an ultrasound and finds his bladder is grossly distended and estimates the amount of urine in his bladder at 1.2 liters. He clearly has urinary retention, and the nurse brings in the Foley catheter. After the Foley catheter is placed into his bladder through his penis, he releases more than a liter of urine immediately. He feels so much better. His vital signs normalize and his pain improves drastically. Now that the patient is feeling much better and his vital signs have stabilized, the doctor explains the situation. Obviously, you know that you were unable to urinate today, and that led to severe pain when you couldn't go. This was likely caused by a worsening of your enlarged prostate. The prostate is located distal to the bladder and it surrounds the urethra. It produces prostatic fluid, helps to regulate urination, and contracts to accentuate ejaculation. The bladder is controlled by the autonomic nervous system. As the bladder fills, the sympathetic nervous system is triggered by sensory nerves in the bladder. It inhibits bladder contraction while closing the internal urethral sphincter, allowing the bladder to fill. When the bladder is full, the parasympathetic innervation overrides the sympathetic innervation and causes the detrusor muscle to contract and the internal urethral muscle internal sphincter to relax. This balance is necessary to prevent premature release of urine, particularly helpful in a flight or flight situation. When a person has urinary retention, the mechanoreceptors in the bladder are triggered and send signals to the spinal cord. This is called the vesiculovascular reflex arc, and it stimulates a sympathetic response that causes systemic vasoconstriction, elevating the blood pressure often to potentially dangerous levels. It is not unusual for the prostate to become hyperplastic and enlarge as men grow older. Enlargement does not mean it will become cancerous, but gentlemen with these problems should be screened for prostate cancer. The enlarged prostate will obstruct the urethra to some degree, and there is a risk that it will obstruct the urethra completely, like what happened here. Acute obstruction is typically caused by inflammation of the prostate. Urination flushes out the system and prevents infection. When there is an obstruction to flow, men are at markedly increased risk of urinary tract infections. The bladder has a transitional epithelium that allows the normal stretch of the bladder. But everything has its limits. Once the bladder reaches its maximal stretch, pressure builds up and triggers mechanical receptors, and then the pressure is transmitted into the ureters, where you will see dilation called hydroureter that halts peristalsis. Back pressure continues into the kidney, which causes dilation of the renal pelvis, called hydronephrosis. This causes the kidneys to swell. Back pressure halts glomerular filtration and can lead to renal failure. You can recover from this back pressure damage if the obstruction is relieved promptly. But if it goes on too long, it can cause permanent damage. For our purposes, let's just review obstructive nephropathy. Again, if sustained, it may lead to renal failure. In all men who present with renal failure, you should consider obstructive nephropathy. It's a reversible cause of renal failure, and reversibility is time dependent. So if you have a man with renal failure, especially acute, the bladder should always be ultrasounded immediately. Obstructive nephropathy is extremely painful and progressively worsens over time. An overdistended bladder and severe back pressure within the urinary tract causes a sympathetic surge, leading to sweating, hypertension, tachycardia, and tachypnea. Pain medication is a neutral action because the best thing to do is actually relieve the obstruction, and that will relieve the pain. Blood pressure medicine is definitely not the answer. The answer is to relieve the obstruction, and the sympathetic surge will end. This is likely to improve the renal injury, if not resolve it completely. It is most commonly caused by benign prostatic hyperplasia in men. Benign prostatic hyperplasia manifests as frequent urination, especially at night, difficulty starting and stopping the urinary stream. A weak urine stream is very common. A feeling of incomplete bladder emptying usually is associated. Men will complain of pain or discomfort during urination. It typically occurs in men who are 50 and older. Benign prostatic hyperplasia, called BPH, is most common in older men. The risk and severity increase with age. About 50% of men between the age of 51 and 60 will have it. Up to 85% of men over 80 have it. Other factors that increase risk include a family history of BPH, a sedentary lifestyle, obesity, type 2 diabetes, heart disease, and certain lifestyle habits, including excessive alcohol or caffeine consumption. The Foley catheter relieves and prevents further back pressure. There's a medication called tamsulosin, an alpha blocker, which works by relaxing the muscles in the prostate and the bladder neck, which makes it easier to urinate. Given time, the medication may work well enough that the Foley can be removed. What if you can't put the Foley into the bladder? Well, there's a special catheter called a Coude catheter. Coude means elbow. This is a firm catheter with an angled tip like an elbow that helps to navigate the tight spots and natural bends in the urethra. If you cannot get anything into the bladder and there is no urologist immediately present to help you, you can attempt suprapubic drainage of the bladder. Catheterization by this route is usually done by a urologist. But in a pinch, if no one is there and the patient is severely hypertensive, the bladder can be drained emergently with an angiocatheter to stabilize the patient. Ultimately, the patient may require a transurethral resection of the prostate, or TURP. This is a urologic procedure where hyperplastic prostatic tissue is removed by way of the urethra in order to reduce or completely resolve the problem. Okay, let's check in with our patient. Drew is back on his feet and living his life. He is very happy for the care and his kidneys are working well. Thank you, doctor. Thank you so much for learning with me today. Please like, subscribe, and review on YouTube, especially if you really enjoy these videos. And I'll see you next time.